Good afternoon, everybody, and welcome to the Wednesday session of Caracon Symposium 2025. The fight isn't over. We're excited for today's session. Before we get into that, let me go through a couple of things. As many of you know, we are Caracol. We are Greater Cincinnati's HIV nonprofit devoted to positively changing lives in the fight against HIV through prevention, housing, and care. We are in a Zoom room today. And if you have any questions that are general questions or you want to interact with other audience members, please put those in the chat. And if you have questions for our presenters today, please use the Q&A function. We have people monitoring them and we'll make sure to get your questions answered. We'd also like to give a special thanks to our presenting partners in Maytech, the Midwest AIDS Training and Education Center, and Hamilton County Public Health. And a big thank you to our main sponsor of Gilead, and then our exhibitor Merck and our other exhibitor Vive. Thank you to all of them. We will be offering continuing education credits for today's session. To obtain those credits, you must be in the room for at least 60 minutes and complete the evaluation by 5 p.m. today. The evaluation will be posted in the chat, and it should pop up as a link for you when you exit the room. If you do not or are unable to get to that link, you can email me and I will put my email in the chat for you, and then you can get the link that way. So today, like I said, we're really excited. One of our presenting partners of the conference is presenting this topic today, Hamilton County Public Health, and they're going to talk about their drug checking program. Today, we have Devin Kinson and Cole Steins, who are going to talk about the work they've been doing. I'm going to go ahead and ask them to come on, and we'll get started. So thank you, and welcome, Devin and
Good morning, everyone. So as Adam said, we'll be talking about our drug checking program at Hamilton County Public Health. Next slide. So first, we'll start with some background of how the program is funded and how often it currently is available, as well as where it started off. So the program began January 2024 after we were awarded the Overdose Data Action Grant through the CDC. And we actually began piloting the program with the empowerment group that is hosted through Caracol. So the empowerment group consists of people who either currently or formerly use drugs. And so we were able to get their feedback, make sure that the program aligned with what the community would most benefit from. And we expanded from there. We started offering it at our syringe exchange, which we refer to as our safe services program. So that's currently being offered Monday through Friday at those sites. And then we additionally have at the Caracol location every other Thursday, we have a designated person that can be there for the drug checking. With the safe services locations, we have limited samples that we can collect, which we will get into later when we discuss the processing of samples. We also occasionally do weekend events, and we still provide drug checking at the Caracol, which is first Wednesday of every month. And to date, we have collected roughly 250 samples. And so to give some background on why this program came about and the value, I'll share some data that we previously relied on for staying on top of overdose trends and how this drug checking data has better informed our surveillance efforts. So we conduct daily overdose surveillance. We use Epicenter, which is run by the state, and it's for overdose emergency department visits, which are assumed non-fatal. And then we also receive data from the vital statistics, which is the mortality data, which provides us information on fatal overdoses. We also attend monthly surveillance calls through Ohio Narcotics Intelligence Center, which combines ONIC and FBI data on drug trends. And the limitation for this data is that they are largely criminal drug seizures. Next slide. So at the local level, in addition to the overdose emergency department visits, we also look at 911 dispatches daily and suspected fatal overdoses through the coroner's office. So these allow us to detect anomalies or spikes in overdose activity and can indicate a bad batch. And where we were previously to having the drug checking program is we would have to assume that there was a bad batch, but we didn't have a lot of information on the local drug supply to inform us and better provide messaging to the community and participants about what substances could be driving any increases. And we've been very fortunate to have the support of law enforcement in our area. And so we meet monthly with a local drug trends group where law enforcement can share criminal drug seizure data, but we can also compare what we're seeing in the drug checking results to see if it matches with what's being pulled off the streets versus what's being used. And then we also value the feedback from the Caracon Empowerment Group and our safe services participants to make sure that the community perspective and voice is always at the forefront of our efforts. And it's to give you a sense of where overdose fatalities currently are. So 2024 data is the most complete year of data we have. There were 194 total deaths in 2024. 74% of those did include fentanyl. And just to give you a sense of where we are in 2025, we only have data through quarter two. But when we look at quarter one through quarter two for both years, we are currently at a 25% decrease. So that is promising, and we hope programs like this continue to see that decline. So when we were beginning the drug checking program, we collaborated with the other jurisdictions listed on this slide. These are also recipients of the OD2A grant, and it's been helpful to hear what kind of sample collection they're able to do. We use different labs, and it has allowed us to expand our reach and get ideas of how we can better market and build trust within the community to get people to bring us samples.
Right, and I'll take over from here. Sorry, Devin. With sample collection and processing. So basically, this is an explanation of how we collect and process the samples. So currently, we accept at all SSP sites, cottons, cookers, drug testing strips, and syringe plungers. Limited SSP sites or call-in or community events, we accept more materials. So this includes pills, powders or crystals, plant material. We've done vape liquid. We've also done some different type of cough syrup liquid. Other paraphernalia would be baggies, trays, packing sticks, pipes, basically anything you can successfully swab out of a liquid or with a liquid and a actual cotton swab or a wipe. And then we put that into the bag to process. So data is gathered this way. Basically, UNC created this card, and it's constantly being updated. But this is the basis for how we collect all the data from them anyway for UNC processing, which I'll get into later. But we built a REDCap survey with this information and added a few questions of our own, like essentially like if they've used the same cotton more than once, if they get the product from the same supplier, just to try to get some consistency to see if it's a one-time thing or a consistent thing within the samples. So from here on our SSB sites, we have a RedCap app is was created with the drug checking program in mind. And basically, they take a barcoded bag, and that matches our kit number for UNC. They scan the barcoded bag, and then they put the cotton or cooker or syringe plunger or test strip in the bag, and then we can go ahead and process it that way. Same with the radar. So radar is actually more what we're using currently for our plungers and for our test strips. This is more of an envelope that has client IDs, and you put the client ID on it, then you put the plunger directly into this the baggie that was shown on the previous page. You put that directly in there, and then just kind of say what is in the substance, and then if it was involved in an overdose is one of the metrics that we have to report to the CDC. This is our sample processing area. We designed this in such a way that when the SSP brings back samples, like the picture on the right there is a good example of our barcoded bag that was scanned through RedCap with the cotton inside. That barcoded number matches the UNC kit. So the SSP staff brings back the barcoded bag. They put it in that little safe that's on top of the cabinet on the right in the larger picture. And we come in then later and we have all of our gloves and other PPE. You can see some of it hanging there, but we have weather wipes and the kits and everything stored in that cabinet. And then we actually process currently in that bin that's there on the far left on the fold down bench top. And that little board that's inside of there is a vial holder that we created so that each vial can sit individually in a hole and it doesn't tip over, which was a problem we had initially with the UNC kit. So it's kind of hard to balance the little vials, and the vials themselves contain a neutralizing solution of methyl cyanide. So when we put a substance in there, that's how essentially then it's neutralized and it can be transported and sent through FedEx. So this is specifically the UNC kits, right? So this is part of the UNC Injury Prevention Research Center. It started in 2022, and they use GCMS with, you could see kind of the technique they're using and a few different types of libraries for their backgrounds. Currently, the processing time is around 3 weeks. And bear in mind that this is confirmatory processing. So on our end, we currently are doing only confirmatory processing, but we have been recently approved for an FTIR machine, which I will kind of talk about in our future goals later on. But you can see all the elements of the kit that we get. So that little blue card there on the bottom left is what the client gets. And the white card, the blue card, the bag, and the vial all have matching numbers. So to keep it anonymous, we don't take any of their information. We give them the blue card, they scan the QR code, enter the number on the website, and that allows them to see what was in their substance. Any of the other materials we don't use. So for the cottons, we usually use kind of the larger scoop, and then the swabs you can see. So you dip the swab into the liquid solution, and then you can swab, like I said, a cooker or tray or baggie, and then you stir it, and that's all we need. The red scoop is the little tiny scoop is all we need for a substance is 1 small scoop. 2 works a little better, but 1 generally is perfectly fine. So it's very, very little amount of substance we actually need to send off. And then there is a glove in the kit that if someone needs to use those, we always have those extra available for them. So this is the other place that processes samples for us. It's the NIST Rapid Drug Analysis and Research Lab, which currently is on quasi shutdown. They're only operating 2 days a week due to being a federal facility. They started around 2019, and they use DART MS initially for all samples. But then when there's an issue like inconclusivity or new compounds to them or isomers, then they go to the liquid chromatography tandem mass spectrometry, which allows them to get a more definitive result. We had one, and we've actually run into a few things where they've had to reanalyze things for us. We were seeing a lot of gabapentin and couldn't explain it, but it ended up being a background substance that was being picked up. It could have been in the standards or something like that. But their processing is quicker currently than UNC. I won't say currently with the government shutdown, but typically their processing time is closer to around a week when we send them in. We just send those little envelopes and we put those in USPS versus the FedEx boxes that are required for UNC. So we can just put the swab or wipe or test strip or plunger straight into the envelope that's pictured there. And then we put that into a larger envelope with our information, send it off, and it makes it, and we get the results back via Excel spreadsheet. And this specifically talks about the results that we have. And so currently we have a REDCap API set up. Basically, it sends the results to the drive if we do a REDCap survey. And then there's also an API set up with the UNC lab analysis results. So that is for UNC, they have both the website, but they also have a CSV sheet that we work off of that's got both analysis and lab results. So basically it says the information that we collected and sent to them. And then it's got the other one that has all the primary and trace substances, as well as a little bit of other information on it. And then we take those two things and we match them up. And I know this picture is kind of small, but basically we take that information and put it onto this sheet. Then we have a separate one that's tied to the radar results. And the goal is to just basically be able to kind of show what they assumed it to be and that what was in the substances. And if there were any weird feelings or any odd appearances or anything, just to see if we have any patterns, like if we've seen a lot of, purple powder over and over and over again, and it's the same substance, then maybe we could kind of give recommendations for folks if it's got a really bad mix of stuff, just to inform the community better. And then the data itself is pulled directly from UNC and NIST and for the CDC reporting, which is actually kind of helpful for us because we don't have any difficult back-end REDCap reporting or anything. It really makes it a lot easier that way. So we appreciate that. And then, like I said previously, the street drug analysis website is where our participants will get the data that's given to them based on their number and scanning the QR code on the blue card. And back to you, Devin.
Perfect. So as Cole just shared some of the results, I'll go a little bit further into what those results look like for participants and then some of the substances of interest that have been identified that have led to alerts. So this is what the UNC results look like for participants. So the chart is the GCMS analysis. The peaks represent the different substances. This is all interpreted by UNC for us and for participants. And on that blue card that was shared in the kit, when they scan the QR code, this is what will show, with also some harm reduction strategies based on what was found in their sample. Here is a breakdown of the total per substance. Again, to date, we've received about 250 samples. And so we are seeing fentanyl in the majority of those samples at 137. And then 4-ANPP is a fentanyl precursor. So no surprise that that is also relatively abundant, and we most often see paired with fentanyl in samples. And then the third highest substance is xylazine, which is a main driver behind how we were able to get such good support for this program, which I will talk about on the next slide. So with xylazine in our area, we were seeing a lot of the wounds and suspected it to be xylazine well before it was showing up in toxicology and even in drug seizure data. That was the only source for us to really identify it in the area. And so it took a while to respond to that emerging substance. Since the program began, these are 4 novel and emerging substances of concern that we've been able to detect early on and be more proactive with responding to. So medetomidine was the first substance of interest, and it was identified at the very beginning of the program, and it's now very persistent in our drug supply with a total of 60 samples that have had it detected. And with medetomidine, it is also a veterinary sedative similar to xylazine. And so we are able to inform participants of the potential impact that it can have and how they can better protect themselves. And now we do have medetomidine test strips available, which we were able to show the need for with these results. Then with the nitazines, these are a synthetic opioid, and they have been detected periodically since April 2024, and some of them are more potent than fentanyl, so another substance of concern. This third substance, BTMPS, is believed to be in the drug supply as a fentanyl precursor. It's an industrial chemical and can have some unpleasant side effects. It's not believed to increase risk of overdose, but it is a substance that is not approved for human use, so long-term effects are unknown. So again, the messaging around that has been beneficial for us to share with the community. And then carfentanil in 2017, carfentanil was believed to really lead to the spikes that we were seeing in fatal overdoses. And so it's something that we are always keeping an eye on. In these 2 samples specifically, it was only found in trace amounts. Next slide.
And I'll discuss the community impact. So medetomidine, like Devin was saying, was first identified in January. And so awareness we've had for a while, especially with, our SSP staff giving awareness to our clients, as well as the empowerment group at Caracon. We started doing having our test strips for medetomidine in July 2025. I know Caracol was able to start theirs a little bit earlier, and other surrounding counties have them as well now, which is great, especially with the new executive order making it so that these test strips are no longer considered drug paraphernalia. So it expanded a lot in that realm. Nitazines, we also have test strips for now. We issued a public alert on July 2024, which was initial response. We continue to monitor for nitazines, but they're kind of come and go. We see small spikes, then they kind of disappear, then they kind of come back. And it's a broad base of nitazines. So it's about every single chemical composition you can think of. We've seen at one point or another, either through our data or what they see in drug seizure side. And then the BTEM, since it kind of, like Devin was saying, looked like it was going to primarily be a form of switch to a different type of precursor when there was a shortage of 4-AMPP. We're just continuing to monitor and make the community aware and kind of see if anyone's got any of the symptoms related to using that specifically. But we have seen where they've kind of tried to break it apart into different chemicals. And then the carfentanil, this is important because we have seen the 2 in our samples, but also there has been a rise on the coroner seizures with in August, they had 40 with carfentanil, and in September, they had 35 with carfentanil. So we want to make sure that we are seeing this as well, so we all can combine our efforts to put out plenty of messaging around that, since carfentanil is such a dangerous substance. And so this is our alert from last year for the nitazines. And this alert was put out basically because we saw about, I want to say around 45 nitazines in about a month worth of seizures, which was quite a spike when we were previously only seeing 3 or 4 per month. And so we, through these types of alerts, the Hamilton County Office of Addiction Response, who we work closely with, shared it with the coalition. So we were allowed to put the messaging out to all those individuals. And then for these types of alerts, our Safe Services Syringe Service program, we currently have a white sandwich board, which we're using to essentially, when we see any sort of substance on the rise in either samples or from one of our partners locally who gives us the information, we're going to communicate that out that way, as well as discuss it with our safe services clients. And then the empowerment group that we go to at Caracon, we always try to give them any information from any new substances that we've seen or any sort of trends that we've seen throughout the county, and so that they can use that information to make informed decisions about what type of substances they want to use or don't want to use. And then we also put these types of alerts on our health or our Hamilton County Public Health website and in social media. So I'm going to mention here some of our future goals and takeaways, where we're headed and what we've learned thus far. So this is a big one, and this is where we have been approved, is for point of care drug checking. And that machine there on the right is an FTIR machine. That one specifically is one of the newer ones they have, which is more water resistant, as a battery built into it and all sorts of stuff. So the goal with that is to effectively have an independent drug checking person at our health department that goes around and is able to go to an SSP. Hopefully we can get into maybe other events like concerts, potentially go to surrounding counties that have other SSPs, and just try to do a regional, a wider outreach of mobile drug checking. And the good thing about that is that that machine there is not destructive. So while we need the CDC, we need some samples to send to the CDC for confirmatory just for our numbers to support the program. The client who gives us the sample, which would be a powder or crystal generally here, doesn't have to necessarily have us send them off, so it doesn't damage their sample. So they can get the powder or crystal back if they want it back. And then we are also working on establishing a dashboard to disseminate our results. Currently, we're sending out results to so quite a few people at this point who want to see them on a monthly basis, as well as sharing them in paper form when we're doing drug checking events and other events like the empowerment group and things like that. The dashboard hopefully will be more of like a one-stop place where everyone can just go and access it, see the trends over time. It'll have some visuals and things like that. So it'll make it a little bit easier and hopefully a little bit more user-friendly for both us and the people looking at it. And then we always are interested in providing drug checking services at more locations. So this, hopefully with this FTIR machine, that allows us to really get an uptick in our services and samples and all the things that we would love to do with drug checking. And that same would be with more community events and participating at those. And we are generally always, schedules permitted, we're willing to do anything. If people have ideas, we're open to ideas. We just have to make sure, we have community agreement essentially. And, just different places we could travel or, potentially get more samples. And then this kind of goes with the same thing, develop partnerships with surrounding counties and medical professionals, which we have been doing a good job with recently. We seem to be having more outreach. And I think the more that we can get out there and the more our partners help us to talk about the program and really spread the message of what we're doing, and also spread the fact that we do not have any intention of giving up anyone's information or anything like that. I think the more samples we've had, the more trust we've gained on that end of things. And so we just need to continue that. And I think the service is just a really good thing for Hamilton County in general and for the people who use drugs in our area. And this is a slide that's got some practical key takeaways. And there's two of the three of us there, or two of our folks there on the right. So things we know about drug checking: it can reduce the likelihood of drug overdoses in communities, just because, like we talked about earlier, the understanding of what is in the supply, like the carfentanyls, the nitazines, the amount of fentanyl, things like that, can help to inform folks to, make sure they're not using alone, things of that nature, or allow them to decide if that is a substance they want to continue to use or not use, and just help them make informed decisions. And the advancing technologies make it easier and more accurate. And that goes both on the FTIR end of things at the point of care, where we would be with our machine, as well as the different types of mass spec and the larger standards libraries that are becoming more available as more substances come into play. And then collaboration amongst multiple partners is key to a drug taking program success. And this is kind of what I was getting at with more community, surrounding counties, community partners like Caracol, medical professionals like the UC Addiction Center folks. It's just really, the more we have of that and the more people that are willing to back us and support us, the better off the program will be. And then drug checking empowers people who use drugs to make informed decisions about supply, which I've mentioned a few times. And that's really our goal, right? Is for the people who are bringing us samples. All things considered, that's who we want to benefit the most from the program. Is, just like a lot of other things, we want to make sure people are getting the best product that they have if they're using drugs, to prevent any sort of overdose occurrences.
And as we expand to partner with other agencies, so we have our quick response team that goes out and does outreach after someone experiences an overdose event, that are planning on coming on board. So our hope is they'll be able to reach people that might not attend our SSP. And then we also are going to be expanding to a surrounding county in the future. So we know with shared borders that there is shared drug supply, and we're hoping that it can give us a better picture of the landscape and just to reach more people.
Thank you, Cole and Devin. I think we've got some questions that may go back towards the beginning, but we'll go through them if that's all right with you all. So the first question is, which one of you, I think, Cole, you just kind of touched on this a little bit, but if you all could give a little bit more information of how you've built trust in the community, because it seems to be asking a lot of somebody who is using street drugs to give you either samples of those drugs or their cottons or cookers or whatever equipment, and to trust that, there's not going to be consequences, I guess. So can you talk about what that looked like?
Yeah, so this was something, early on, I will say the empowerment group was kind of the first pilot part of this. And that was actually Devin kind of started on that side of things. And that was an initial way to kind of look at how to build that. Once we started going out to the sites, it was a slow process. I will say that. But our SSP staff was great to support us, and the people trust them. So once we started getting some samples and getting them out there and sending them off, and people realized we weren't doing anything with their information or anything like that, um, just being out there, we had, some sort of incentives initially with like snacks and waters, which we try to do when we can anyway, continue to bring that, just to kind of make relationships with people. So there was a lot of days, especially early on, where Devin or I would be standing out there for 2 3 hours and not get a single sample. But I think the frequency and, seeing us over and over again, being kind, just simple things like that, it helps, it goes a long way. But then the SSP staff standing with us, and it's all just sort of communicating and not being pushy, but more just kind of, explaining the benefits of the program. I don't know if Devin, if you have anything else.
Yeah, I think certainly once we had results to share, that helped people to realize other people were taking part in it and they hadn't heard any negative outcomes from that. But then also trying to be transparent with the process. We would bring the kits out, explain why we were collecting certain information, but also the emphasis was always on the fact that it's anonymous and that we do now collect SSP IDs, but we always offer the option to collect any random number that's meaningful to them or a code name or anything that makes them feel more secure with sharing information with us. And also having a private space, I think, helped.
And the SSP IDs are, just so everyone knows, they aren't shared outside of internal. So we just have those just in case someone loses their blue card. But they don't get shared with the CDC or NIST or anything else. It's just so that we can kind of keep an idea of where it came from.
Thank you. That's some really good information. I wonder, through that process, did you identify any like community champions or people that were able to kind of speak on your behalf to that community and then maybe brought people in?
Yeah, I will say that the empowerment group were huge champions. So the first 2 years of the program, we hosted drug checking events, which unfortunately always had bad weather on those days, but we still had a pretty good turnout, and the empowerment group helped us run those events. So they were familiar faces in the community. They could bring people over to the table. And I think that helped a lot, seeing that we had a relationship with them and that they were championing the program.
That's great to hear. Thank you. I, yeah, I think you're talking about a community that's very, is treated maybe not with the most respect by society. So, I mean, I've found over the years that, just treating somebody with respect who usually doesn't receive respect goes a long, long way.
Mm-hmm.
So it sounds like that's something you're employing a lot.
Yeah.
We got a question from, well, an anonymous attendee. And it's asking, can you discuss further the value of getting feedback from people with lived experience? I guess just more of how you incorporate that. And to add on to that question, I'd be interested to know, what is your funders' feedback from that? Like, how does the CDC look at how you're um, engaging with people with lived experience?
Yeah. So I think the greatest feedback that we get, well, we get a lot of different feelings, which is helpful. So what people, what they've perceived in specifically to like how the drugs affect them, right? And the patterns that are built there, which is something the CDC does have interest in just due to the broad base of understanding of what's in the supply kind of everywhere. But that feedback is pivotal as well towards our understanding of how people have used substances and use substances, especially like I said, when it comes to like using things like naloxone or never use alone, and how they specifically have plans to use with a partner and how they execute those plans, whether one person tries it first and the other person watches, or vice versa, just depending, which has been really interesting. And I think those are kind of more intimate details that have been shared with us, right? That go kind of beyond the drug checking aspects that we do, where people are willing to share their processes and sometimes just admittedly say they're not ready to get off drugs or anything like that. We aren't, obviously any sort of treatment provider. We obviously know treatment providers and things like that, but we're not the ones who are ever going to say, "Hey, this is what you should do," without the person asking, voluntarily, or submitting that type of information. So that, and kind of the interesting things we've learned about, like, where uh, testers and things like that we probably previously wouldn't have known, where people will set up methadone clinics and things like that. um, just the things people share with us just helps for us to broadly understand the landscape that we're dealing with and those types of things. So
Yeah. And I think the other benefit of having that lived experience voice is when we started out the program, we were only collecting used cottons. And while that was the easiest sample to start with, the feedback that we were getting was that's asking someone to carry additional paraphernalia with them when they're already bringing syringes back to the SSP, or there is maybe a lower risk sample that they can provide us. So they're not putting themselves in jeopardy by just trying to be better informed about what they're using. And also, we like to have their feedback whenever we are messaging about emerging substances, to make sure that the harm reduction messaging is realistic and feasible and doesn't just promote fear.
Thank you for that last part, not just promoting fear, because it seems to be a lot of what happens around drug use in the United States. You had talked about, you're sharing your data and everything with a lot of different groups of people, and working with a lot of different organizations and groups, one of them being law enforcement. Can you talk about a little bit more of how that relationship works, kind of what they're looking to get out of your information? Um, and when you're working with law enforcement, did they have any, are you ever in situations where they're having an interaction with the people you're getting drugs from to test? And like, because that also seems like, you're again asking a lot of somebody who's using street drugs. So I just wonder, how does that shake out?
So I can speak a little bit. So the thing that got us kind of, well, we've always had Chief Tom, which he's kind of a friend of Caracol that comes around, and he's been to the empowerment group and stuff, and he's a champion. He's part of the Hamilton County Addiction Response Coalition. But the thing that kind of got us connected in a way is that our program was pretty small but moving, but we started seeing substances that they weren't even seeing in seizures. So, like, methamphetamine is a good example, where we saw that substance before anyone else in the county saw it. Right? They didn't even have standards for it at the lab at the coroner's office. So then they kind of started asking us, in an effort to just kind of see what those substances were in the county. And we collaborate insofar as that all of the sample data is publicly available. We collaborate so that they see that data, and we'll discuss maybe those samples, like it was seen in X, Y, or Z sample, but it doesn't really go beyond that. Their goals are different from ours insofar as some of theirs are more diversion and deflection, those types of things, and looking for the larger suppliers at hand. But it is helpful to see patterns like the B temps and things like that, and get a better understanding from a regional perspective, because the the more people you have kind of looking at the large mixes of substances, the better basically understanding of the substance that we can have in order to inform both our SSP clients and any other groups we want to talk to, right? Because when we first started seeing like the B temps or metatomedy, no one knew what it was, and then Philadelphia often sees this stuff before us. So a lot of what we do on our end is look at things in their area, because usually if they've seen it a month ahead of us, they're already working on like things on the medical clinical side to prevent withdrawal for like metatomidine, or how if someone shows up with that, what to do. Does it cause wounds like xylazine, things like that? So that's just another connection, and some of that is also law enforcement related. To answer your question about if we've ever had anyone with law enforcement stand with us for the drug checking, no, that wouldn't be something that we would be comfortable with. I don't know that they would be comfortable with it, but also we want to make sure people aren't being targeted in any way. Our goal is not at all for anyone to get in trouble for bringing us a substance, paraphernalia, whatever, because it's enough of a risk on their behalf already. And even though they're within safe distance, especially at our SSP sites, we give out the cards. That's still not to say that, once they leave that surrounding area, they could be the target of law enforcement. So it would go against everything that our program is trying to do. So.
And it's also been valuable working with law enforcement with supply chain interruptions. They often are curious, are people having the experience of a weaker supply, and are people's tolerance down? And then when we start seeing substances like carfentanil, their concern is that would lead to an increase in overdoses. So they have the information on seizures that might be occurring or underway, and know that inadvertently, by removing someone that's been supplying, then people are switching where they're purchasing, and that can harm the community. So I would say the law enforcement that we work with is invested on preventing that from occurring, which has been great. And the other thing I'll add is the grant stipulates that any of the samples we provide to them cannot be part of a criminal investigation. And then UNC also states on their website that the results aren't admissible in court. There's no chain of custody, anything like that.
Well,
Yeah,
that's
one
great to hear.
example of.
Sorry, go ahead, Cole.
No, I was just going to mention, like, with kind of to Devin. So this kind of happened in June, where we saw an uptick in cocaine-related fatalities, unfortunately, and that had to do with the supply chain issue, right? So people who were just looking for substances couldn't find any fentanyl. They switched substances. The theory is they have pre-existing heart conditions. You switch from an opioid to a stimulant, especially if it has been a long time. And then so we saw just a random spate of overdose deaths related to cocaine, which we hardly ever see anymore. The actual things like cocaine, heroin, and things like that just aren't something we typically see alone in toxicology, but some of those were just cocaine. So.
That's great to hear that there's also some guardrails coming down from like UNC and the CDC around law enforcement. If those weren't there, then I think, maybe certain law enforcement might try to use them, or, so it's good that there's guardrails there. And for those of you that aren't aware, Cole mentioned Chief Tom Simon, who's a chief here in Hamilton County, and he's been a champion of harm reduction programs for years and years and years. He's kind of ahead of the curve, especially considering he's in law enforcement. So I think he's probably a really good partner for you all. I also mentioned, like, earlier you showed the different jurisdictions that were funded under this OD2A grant from CDC. I was surprised that 3 of them are in Ohio. Can you talk? Why is that? That seems like an awful lot to be in one state. And then I also wonder, are you, when you're like seeing what Cuyahoga or Franklin County are seeing, are you seeing big differences in their drug supply versus the drug supply here in Cincinnati?
Yeah. So I can start off. It's been really interesting. So we have ongoing conversations to share the results that we all have been having. We definitely have differences in drug supply. So they don't see xylazine and medetomidine like we do. And one stipulation is we have very different programs. So Franklin County started off only collecting used test strips, and that was largely due to the lab that they were partnered with. And then, if I'm not mistaken, Cuyahoga only collects syringes. Is that correct, Cole? So
Yeah.
then you're only getting information on the drug supply for people who inject drugs, which I would say, predominantly see as well, but we do try to make sure that we're expanding the program to reach people who use in other formats. And to speak to why, unfortunately, Ohio has been impacted by the opioid epidemic. More than other states, I would say. So Franklin and Cuyahoga see quite a few fatal overdoses and overdose activity.
So it's more that, as has been the case for years now, Ohio is one of the epicenters of this epidemic we've got going on. Well, that's interesting to hear. So you all are kind of looking at different things. You have different ways to go. So it is not, you don't really have the ability to compare apples to apples. Gotcha.
Correct. And one thing we've learned with test strips and syringes is they can be very good, but they also can be not have as much because the residue's harder to get off. Like the true gold is getting the actual substance. And then I would say cottons and cookers, we get very good sample return from. And then it kind of goes down, right, to like sticks and pipes and things like that. But the test strips and syringes are good because we get samples. They're just harder for them to analyze, I believe, on their end and get a true result because of just the variances in how people test their drugs, how much quantity they're using and things like that, or how many times the syringe has been used or what it's been exposed to. And oftentimes it picks up like plastics and lubricants in the syringe itself. So that can kind of make it a little bit more difficult just because it's the base background substance. So they have to separate those chemicals out. So we really like, ideally, if one of us is there, like the actual substance, but the cookers and cottons are great too. Those are kind of like what we really like to see the most. And that's something we've learned over time. And our program is a little bit ahead of theirs, but what's good about that is we've been able to share our different hurdles and barriers and things we've run into with them. So hopefully it helps progress their programs. And that's the other ones on there too, even the out of state programs. Some of them are a little bit ahead of us. And so like Seattle King County's like way ahead of everyone. But then when we look at like Hennepin County, Minnesota, they're in the infancy of their program. They haven't even started getting samples yet, but it's good because we can share how we're using the data, how we're collecting samples and things of that nature. And it's been really helpful to talk to different folks and get their experiences.
That's awesome. And around that same time in the presentation, you had mentioned, I think Devin, you were going through this part of it, but you had mentioned that there was in the first 2 quarters of 2025, at least as we're looking at it right now, we're seeing like a 25% decrease. Do you have anything to attribute that to right now, or is it too early to kind of have an idea of what might be causing that?
Yeah, we can't speak to the exact causes. Over the past few years, we have seen that decrease. And so we hope that it's a result of more programs and trying to expand programs into the zip codes and areas that have been impacted the most. There is belief that it could be related to a weaker drug supply, but it is difficult to pinpoint any one cause.
Sure. And then we've got a question here. It says, how can we, as people working in this field, help with staying ahead of drug trends? I think, it's to inform people, like what would you suggest to, kind of have your ear to the ground on that?
Yeah, like I said, we typically research other jurisdictions that we know are like if we're talking specific to just our city, it's kind of can be a slightly easier on us because we have data coming from the East Coast. Now, in places like Kensington and Philadelphia, they get hit hard and they get the new substances and things like that. Some of them come from the West Coast. Their situation is going to be a little bit different with how they can see trends like new drugs coming in, things like that, because they might be the first place to ever see it. And so for us, it's key that the labs give us information. So like NIST with their information they give us, they're based in Maryland, not too far from Washington, D.C. So they see a lot of that stuff first line. But I think following those types of things as a harm reduction worker, like UNC analysis, CFSRE is another great one, NIST, and keeping up with that type of communication coming from either direction, but especially the East Coast to where we're at, has been the most helpful thing so that we can see like, all right, they're seeing this stuff. We're getting samples. We're starting to see it in corner. So we can actually see like, is this going to come our way? And there's usually some pretty good research and stuff behind it, especially substances that we're starting to see that have been in Europe primarily or Australia. There's good research showing the effects or if those are analogs or different things like that.
And I will add to that in periods where we've seen fewer samples returned, especially with the 3-week turnaround time, the value for the drug participant isn't always there. And so we have had periods where we are hearing from other jurisdictions some new substances that, for example, like VTMPS, when we first started seeing it but didn't have the samples, we would just ask participants if they were experiencing any of the hallmark side effects. So ringing of the ears, a particularly chemically odor or taste. And that can sometimes help us know that even if we're not getting the samples to demonstrate that it's in the supply, we can have a strong suspicion. And I would say that's also true for medetomidine when we were starting to hear reports of hallucinations or people just immediately being knocked out. Those were kind of indicators to us that it was more prevalent than even our results were showing.
Interesting. And there's something going on in Philadelphia because you're right. It does seem like a lot of the new adulterants that we see seem to be at least first detected in the Philadelphia area, which is interesting. I've got another question here. It says, as drug checking efforts have expanded, have you noticed any trends for how the use of certain substances spread geographically? So I guess the way I'm reading that is maybe, are you seeing anything where you might see certain groups of people maybe on the west side using drugs and then it spreads to another side or vice versa or something like that?
Yeah, this is kind of something I know we've put some thought into, and this is the importance of having a better regional drug checking type of system because, if we only ever got samples from north side, all we can say is, if people are buying within a, 5-mile radius of north side, you're probably going to see very similar types of samples. But, I think we haven't seen anything that's like super, super different. So even if we have an SSP, our SSP in Coreyville or wherever we're picking it up from, it's been pretty consistent. If we were to take 5 samples from there, 5 samples from Price Hill, and even 5 samples from up north, they've been pretty consistent thus far. But it would be interested even on the farther outreaching places to see what we'd have.
And I will say, while we can't really speak to changes across the county with use or even results, we do see at least for some of the participants, reported change in behavior around use based on results. So really utilizing xylazine test strips, and sometimes reports of changing supplier or keeping their supplier, since they now know that they can trust what's in it.
I got 2 more questions, and then we'll cut the questions off. But this first one is I think pretty quick and easy. But I think some of the audience was surprised that this is being sent through FedEx or through the mail to the labs and everything. Have you had any issues with that? Nothing.
Nothing. Yeah. So the UNC ones, like I said, those are it uses the methyl cyanide fluid. We just drop the thing in there, throw a bunch in a box. It's got a pre-made sleeve and box for us, and we put them in every sort of FedEx box, dropped them off at the FedEx store. No problems with that. And with the NIST envelopes, since we primarily have been sending test strips, plungers, or their type of wipe, it depends on, we're not sending like the actual cottons and things like that. So I believe that they have some sort of system where it's technically been, it could be considered paraphernalia, but it's technically used. So we've not had any return to us or anything like that thus far. And yeah, we were even with the NIST ones, especially when they're like, you can just throw them in an envelope and send them USPS. When UNC had this like system and this solution and stuff, we're like, all right, we'll give it a whirl, and we've never had a problem.
Yeah, the solution that UNC has completely denatures the sample, and yeah, just assuming that the quantity is so low for NIST that it doesn't matter.
I mean, I guess if you can get like chickens mailed to you through USPS, you can mail drug paraphernalia. And then the last question is, through this drug testing, are you able to show like the origins of these adulterants in the drug supply? Or like, is there, maybe not you all, but is there like the CDC or another group that is trying to backtrack those to see like, where is this originating from?
I would say we get some of that information from the drug trends group from law enforcement, where they're able to see where it's been detected elsewhere.
Yeah, I'd say that between that and just, like I said earlier, like regional data, we don't go to that level of where we would ask someone specific information. Like if they've told us they got it outside of a methadone clinic, we don't ever say which methadone clinic, stuff like that. So I think it just kind of goes, we want to inform that the substance is in the area, but we're not trying to pinpoint any specific location to where it's directly coming or where it started. Just because that's just not the nature of what we're doing specifically.
Thank you for sharing with our audience, and have a great rest of your day.